Welcome to Texas Heart Institute Educational Programs, Innovative Technologies and Techniques. I'm your host. My name is Zvonimir Krajcer. I'm an interventional cardiologist at Texas Heart Institute and Baylor CHI Medical Center. We have a unique opportunity here and a special pleasure to have a special guest at this presentation, Dr. Stephanie Coulter, my associate. Welcome, Dr. Coulter, to this presentation.
Thank you for having me, and I'm so happy that we're highlighting this very important problem that's predominantly found in women these days.
Dr. Coulter is director at the Center of Women's Heart and Vascular Health at Texas Heart Institute. She's also a program director of cardiology fellowship at Texas Heart Institute at Baylor St. Luke's Medical Center, and associate medical director of non-invasive cardiology at Baylor St. Luke's Medical Center, and director of education at Texas Heart Institute. Dr. Coulter, can you tell us about women's programs at Texas Heart Institute?
Well, Dr. Krajcer, thank you for the lovely invitation to be part of this novel series of educational programs. We founded the Women's Heart Center here about 10 years ago, so we're about to hit our 10-year anniversary. And since that time, we've invested our resources into making collaborative projects with community partners here in Houston, Texas, where we were interested in learning about why women had disparate outcomes from vascular disease that we thought were related to ethnic and racial differences. We've done community screening exams through some local community partnerships and have looked at cardiovascular risk, and we've also been part of a women's focus research group where we've also collaborated with the School of Public Health and the University of Texas as well, looking at non-vascular causes of vascular disease. We're looking at things that happen primarily in women, including fibromuscular dysplasia as well as diastolic heart failure.
Very good. Thank you very much for this information.
Dr. Krajcer, today's topic is on chronic venous insufficiency in women. In my practice, I see this every day, and you know, in the past we weren't so aggressive about how we took care of these people. In fact, I've seen some of your slides from today's presentation, and I must explain to you that I'm actually guilty of some of the commentary that you ascribe to doctors, namely that we don't think it's a big medical problem and that we've just pretty much made women continue to suffer and told them it was a cosmetic problem. Can you briefly describe about the venous anatomy of the lower extremities and what exactly is venous reflux disease?
Well, thank you very much for asking me this question. Venous disease is very dear to me. I've been treating venous insufficiency for several decades, and it is a major problem, as you will see from following presentation. In essence, when we talk about venous flow in the lower extremities, we have to know that there are two systems. There's a deep venous system and superficial venous system. The deep venous system is extremely important because it carries more than 80% of the blood flow from the lower extremity to the heart. The superficial venous system is less important and is more frequently involved in disease and problems with chronic venous insufficiency and reflux. As far as the superficial system is concerned, we have a greater saphenous vein. It comes basically from the inguinal area all the way down to the ankle on the inside of your leg. And then we have a lesser saphenous vein, which is located from the knee in the posterior position of the leg, and it goes all the way to the ankle. And of course, then we have many tributaries to both systems, deep and superficial, as well as communicating veins or so-called perforators that communicate between the superficial system and the deep venous system. One very important aspect as far as the venous circulation is concerned is functionality, and how does the venous system in the lower extremity work. Arterial system is totally different as far as the blood flow is concerned because it's driven by high pressure. The venous system is a very low pressure system, so the only way how we can actually stimulate the blood flow from the lower extremity all the way to the heart is by contracting our muscles and by intrathoracic pressure changes with inspiration. Now, for the gravity to cause problems, we have valves in the venous system, and the further down we go to the leg, the more frequently we see the valves. And the valves are extremely crucial to prevent the return of the blood flow to the bottom of your leg. Once the valves fail, then we have a problem with regurgitation or a valvular insufficiency in the lower extremities. Now, venous reflux basically occurs because the valves fail to function normally. They should open and close, and that particular function is extremely important for good flow of the venous blood from the lower extremity to the heart. Many factors contribute to that, but essentially what happens, the pressure increases in the venous system in the lower extremity, and the veins stretch, more frequently superficial than deep, and then you develop valvular incompetence or regurgitation. Now, as far as the perforating veins are concerned, and those are the veins that communicate between the superficial and the deep system, the valves also should function in a unidirectional fashion, allowing the blood to flow from the superficial system to the deep system. Once those valves fail, then we have reversal of the flow, where the blood is returning from the deep system to the superficial venous system, and that eventually leads to further dilatation of the superficial venous system and valvular incompetence.
Dr. Krajcer, how prevalent is chronic venous insufficiency?
Well, it is a major problem all over the world as well as in the United States. And it is estimated that roughly between 30 to 40 million people have symptomatic chronic venous insufficiency. Of course, significantly more individuals have disease without identifying their problem or symptoms. It's interesting that only 1.7 million out of 30 to 40 million seek treatment annually. So therefore, somewhere in the range between 28 to 30 million individuals have not either diagnosis or do not undergo treatment of this condition. Now, another very important information is that chronic venous insufficiency is 2 times more prevalent than coronary artery disease, and 5 to 10 times more prevalent than incidence of peripheral arterial disease in the lower extremities. Now, it is also important that venous insufficiency accounts, as far as the superficial veins are concerned, between 70 to 80% of the symptoms. So this is a major culprit to venous insufficiency of the lower extremities. And in patients with chronic ulcers, it is a culprit in 84% of instances. So the superficial venous system is more frequently, more commonly involved in this disease than the deep venous system. Now, additional information related to chronic venous insufficiency that is very important is the cost issue with this particular disease. It is estimated that we spend somewhere in the range between $150 million to $1 billion per year in the United States treating this condition. And over 500,000 people are hospitalized annually with a diagnosis of chronic or DVT and chronic venous insufficiency problems. So Another important feature is, as far as this particular information is concerned, that it affects all age groups. Yeah. It is frequently thought that it affects only older individuals, which is not true. As far as varicose veins are concerned, the prevalence among the general population ranges between 5 to 30%. And as far as adult population is concerned, it is more frequently seen in females than males, and the ratio is somewhere between 2.1 to 3.1. And that's very important to know. From my point of view, treating this disease for many decades, I personally believe that there is a tremendous problem with this particular condition. I think it's the most underdiagnosed condition, most ignored condition, most misdiagnosed condition, and most undertreated medical condition.
Why do you think this is the case? Are we at fault as the physicians?
There are many factors that play a role, but I think that there is definitely a misconception. This is just a cosmetic disorder. It is a cosmetic disorder in a lot of instances, but it carries significant medical consequences on short-term basis and long-term basis. There is so very little awareness among healthcare professionals, and that includes not only cardiologists but also internists and all the specialties involved, where we are not adequately educated on severity, incidence, and complexity of this disease. Providers are unaware that in right hands and with appropriate treatment, there is usually a very rewarding outcome as far as treatment is concerned. And there is also a failure to link venous insufficiency of the lower extremities with conditions such as leg swelling, leg edema, leg cramps, pain, restless leg syndrome, and venous ulcerations. Very frequently this is misdiagnosed as heart failure or sports injury or whatever other injury, or peripheral neuropathy and many other conditions. So failure to consider the symptoms burden and tremendous suffering of these patients is really a very sad type of a scenario that we have to deal with. Hence, venous disease remains a major cause of preventable morbidity and mortality, and I call it the forgotten side of circulation. We pay so much attention to the arterial disease and arterial circulation and peripheral arterial disease, yet the venous disease is much more prevalent and easier to treat with more rewarding results, particularly if it is diagnosed early.
Dr. Krajcer, what are the usual symptoms, and do you think we could make a dent in the incidence of the disease by having maneuvers to prevent venous insufficiency long term? Like, should we all be wearing thick stockings? I mean,
well, some of us
because
should.
I don't want to end up with legs like this one day.
Let me tell you who should wear thick stockings.
Yeah, pregnant women, nurses,
right,
teachers,
cardiologists,
standing up all day, surgeons.
How about truck drivers that drive for 12 hours
they
and
definitely need them too.
Sedentary positions, secretarial
but everybody
positions.
Sits.
Right. Absolutely.
Right. So we all need compression hose.
A lot of us.
Yes.
But let's first go to the symptoms, because symptoms are extremely important and they are frequently not paid attention to or misdiagnosed. Mm-hmm. For instance, aching discomfort in lower extremities after a long day is interpreted of old age, tiredness, lack of exercise, decondition, and so on.
Or it's your statin, because they like to blame their cardiac medicine, so in our world.
Exactly.
Yeah.
Leg or foot cramping. This is a very common feature, and I would say more than 80% of patients with chronic venous insufficiency have symptoms of leg cramping. Now, what's very important is to know how to ask your patients in the best way about their symptoms. A lot of patients might not understand medical technology or might not understand when you ask them something like, do you have leg cramping? Frequently I will get an answer, no, I don't have leg cramping. But you ask them, do you have a foot cramp? Oh yes, I have foot cramp. So you have to know how to ask specific questions that will give you the correct answer and the correct diagnosis. Sometimes patients experience just heaviness in the lower extremities, particularly after exercising. Pain is very common. Sometimes they'll experience burning sensation, tingling, numbness, itching, and of course then in more advanced situations you will get swelling or leg edema in the lower extremities, particularly around the ankles. And interestingly enough, restless leg syndrome is in more than 90% of instances caused by chronic venous insufficiency. There are some neurological disorders that also cause restless leg syndrome, but in most of instances it is related to chronic venous insufficiency. And why does it occur? It's a spontaneous, subconscious reaction to correct the problem by moving the leg, pumping your muscles, and pumping your venous blood upward. So,
in the leg that's dependent, the pressure in the veins, it should be really low, like 10 millimeters of mercury or less. But if you sit for a long period of time or you stand at attention for a long period of time, the pressures in people that have chronic venous insufficiency, the pressures in the bottom of the column of blood can be as high as 40.
right, it triples or quadruples.
Yeah, and the only way to get that pressure down would be to walk around and contract the muscles.
That's right. So once we get further as far as progression of the disease is concerned, we start getting ulcers.
Well, the first you get just changes in the color of the skin, right?
Well, those are findings that we see, not necessarily symptoms. But you get ulcers, you get thrombosis, you can get bleeding, you can get cellulitis, and all of those things. So we have to pay attention to all of those symptoms that can occur, and there are several other ones. Now, what I see very frequently, patients are referred to me, or I see patients on consultation, and they tell me that they have a diagnosis of peripheral neuropathy because they have tingling, they have numbness, they have pain, paresthesias, and they've been treated with a variety of medications that do not work. And we examine them, we listen to them, we obtain venous insufficiency study, and we make the diagnosis of chronic venous insufficiency and correct the problem, and the symptoms in general disappear. Of course, there are conditions that cause peripheral neuropathy, and particularly in patients that are prone to that, such as diabetics and so on. But I would say the great majority of those patients that have those symptoms have them because of chronic venous insufficiency.
What is the pathophysiology of chronic venous insufficiency?
With venous insufficiency, we invariably have venous hypertension. Of course, you could get a valvular incompetence due to genetic factors or genetic factors influencing the structure of the venous system in general, such as propensity to disrupt the elastin in the venous wall, and you get progressive dilatation, and that leads to valvular incompetence. But in general, it's related to hypertension. Hypertension could be due to many different causes. For instance, heart failure and tricuspid insufficiency can cause venous hypertension. Obstruction of the vena cava with thrombosis and IVC filters can cause it. Pregnancy can cause it, and a lot of surgical procedures, which is particularly more common in women, such as hysterectomies, oophorectomies, that can interfere with the venous flow, or traumatize.
Or even C-sections.
Or even C-section has significant consequences. And I think this is one of the reasons that this condition is more prevalent among women. And then another feature, obviously, is menopause, hormonal changes, weight gain, and so on. So all of those things play a significant role in developing this condition.
What are the stages or classifications of this condition? This is a medical thing. We like to put a number on them. So
Now we're coming to the point of view of how do we identify this condition. Of course, we have classical features that we can see on the skin or near skin, and then we have features that we can identify with
The
non-invasive evaluation and the Doppler. So as we can see here, we can have a chronic venous insufficiency without any obvious external signs.
right.
I have seen young women without any evidence of varicose veins or spider veins or telangiectasias, and yet they have symptoms. This means that they have symptoms and they have abnormalities in the venous circulation that did not get to the point where it becomes visual.
Not yet.
Right.
Just give them time.
So we have this CEAP classification from basically 0 to 6. And we can see here that you can basically start with a normal leg, and then you get telangiectasia, spider veins, and so on. Then you get to varicose veins, and then you can get hyperpigmentation,
Yeah.
and then eventually to ulcerations and infection. Now, what's also very important is when we get to that last stage, or stage 6 with ulcerations and infections, there is a misconception that most of those ulcers are caused by arterial disease and insufficiency in arterial circulation. And as a matter
But it can do it too.
It can. But as a matter of fact, in general, when we see ulcers in the lower extremities, nearly 80% of them are caused by chronic venous insufficiency.
When should you look for chronic venous insufficiency? People with symptoms, people with signs, people at high risk?
As we get older, this condition becomes more prevalent for a variety of reasons. Family history is extremely important. And that's true not only for female gender, but also for male gender. But I think that we always have to pay attention to other factors as well, such as history of DVT, previous history of phlebitis, whether it's superficial or deep, trauma, surgery, particularly as I mentioned, pelvic surgeries. And then another condition that is very prevalent is May-Turner syndrome, which is actually compression of the iliac vein by iliac arteries. This is a relatively common condition that occurs in general population. On an average, as far as female gender is concerned, between 25 to 30% of female population have features of femoral vein compression, or so-called May-Turner syndrome, and maybe somewhere in the range between 15 to 20% of the male population. Now, of course, a lot of us do not have classical features or symptoms, particularly not in our early age, but as we get older, with other factors, whether this is surgery, weight gain, pregnancies, and so on, then May-Turner syndrome or compression becomes more pronounced and more important. And of course, obesity, standing, occupation, we talked about it previously, different professions, sedentary occupation, again, pregnancy, and as we discussed before, female gender.
So why do you think venous insufficiency is more prevalent in women? Obviously, the pregnancy and the pelvic surgery would be more common in women.
Well, we talked a little bit about family history. It's a genetically transmitted disorder. In about 70% of patients with varicose veins have family history. And it doesn't have to be only your mother, but it could be your father or your grandmother and whatever. So that is very, very important. Pregnancy is extremely important. And 80% of women develop varicose veins during pregnancy. In a lot of instances, they improve over a period of time. But in certain instances, it can persist and continue to cause problems. Occupation, long-standing or sitting, obesity obviously causes hypertension on the venous system because it's a very low-pressure system. And again, May-Turner syndrome, which is more prevalent in women.
When would additional diagnostic evaluations be indicated?
And also, not only as far as evaluation is concerned, but taking into consideration differential diagnosis. I think anytime the patient presents or you find the patient has classical symptoms of chronic venous insufficiency, you should perform additional testing. And you should always consider differential diagnosis. And in differential diagnosis, there are many different entities that could be causing similar symptoms, and vice versa. I have had, for instance, patients that underwent back surgery for leg pain and leg discomfort and paresthesias and so on, and their symptoms didn't improve. And actually, the correct diagnosis was chronic venous insufficiency. However, there are also patients with low back syndrome and lumbosacral disc disease and sciatica that have primary problems with this particular issue rather than chronic venous insufficiency. So you have to be able to differentiate what is causing the problems. There are other conditions such fibromyalgia can cause tiredness, achiness, discomfort, pain, different forms of vasculitis, arterial disease of the lower extremities, which frequently occurs with chronic venous insufficiency, and sometimes mimics, or they can have exactly the same symptoms. Patients with chronic venous insufficiency can have claudications, discomfort, with physical activities, as well as patients with peripheral arterial disease. Lymphedema. Lymphedema can be confused with chronic venous insufficiency because of the swelling. But interestingly enough, chronic venous insufficiency can also cause lymphedema in more advanced situations. And so you have to be able to differentiate those two. Arthritis, the patient will complain of aches and pains and discomfort, and actually it could be osteoarthritis or other types of arthritis. Neuropathies, as we discussed before, chronic heart failure with causing leg edema, liver failure and leg edema, arterial hypertension, obesity, surgeries of various kinds, and previous injury to the venous system as well.
What tests are you recommending to do a proper evaluation for chronic venous insufficiency?
Well, thanks to you and your expertise in the field of Doppler and duplex scanning, not only in the heart but lower extremities, we have used this particular approach very extensively. And this is what I would call our gold standard in venous imaging. Duplex ultrasound is extremely important in screening patients before the procedure. Of course, we routinely use it during the procedure or treatment with various modalities that are available, but also we use it as a follow-up tool to determine the results and outcomes of treatment. So as far as the technique is concerned, most commonly this is done in standing position, and we could use a variety of maneuvers to augment the venous flow and also stimulate the regurgitation through incompetent valves, either with Valsalva maneuver or compression distally or compression proximally. And we have to know where to put a probe and identify the intensity of reflux. Basically, that is done in a length of time that regurgitation occurs across the incompetent valves. The normal value is less than 0.5 seconds of regurgitation, and when it's more than that, then we interpret it as reflux of a significant degree or chronic venous insufficiency. Typically, in more advanced cases, we will see up to 7 seconds of regurgitation across the regurgitant valves, and that will be seen in more advanced cases. And here we can see actually the technique, an example where that regurgitant flow is with a Doppler identified, and this particular case occurred in more than 7 seconds. Now, there is also a misconception that all the diagnostic labs that have a Doppler or duplex equipment available can accurately identify this condition. In more than 90% of instances, this condition is misdiagnosed or not appropriately diagnosed or not interpreted well. So I would say that the labs have to be well equipped and personnel has to be well trained to be able to do a proper diagnostic study.
So it's not the same exam, a Doppler duplex study, that you might ordinarily get if you were looking for blood clot in the legs, because this test you have to be standing up to prove that there's backward blood flow in the veins.
Right.
So laying down, you can't eliminate. You can't say you don't have it. You may not have it laying down, but when you stand up, you do.
Right. You're absolutely correct. In a lot of diagnostic labs, when you order a venous Doppler of the lower extremities, they look for thrombi.
That's right.
Thrombophlebitis. And they'll say present or not present. Present in deep system, present in superficial system. But actually a complete study should include, in addition to that, evaluation of valvular incompetence or insufficiency in deep system as well in superficial system. Now, when you do that, you should interrogate the whole superficial system, the whole leg. You should look at the greater saphenous vein. You should look at the anterior accessory, if there is, posterior accessory, lesser saphenous vein, and also perforators, which is very important.
Are those harder to pick up?
They are.
So you have to have a talented sonographer.
They require great expertise, no doubt about it.
So I know you're going to do a separate teaching module for the specific treatment. Can you give us an overview of what that kind of treatment looks like?
Well, there are many different modalities available. Of course, the first modality that was available was surgical approach. Surgical approach with what we call vein stripping.
Yeah.
And that was done for decades. And the procedure was very successful. However, it's an in-hospital type of a procedure. Was typically done under general anesthesia. It requires surgical incision at the inguinal area, at the knee, below the knee, and at the ankle. And the surgeon would pull or strip the vein. And that obviously carries certain complexities and consequences as far as pain is concerned, risk of general anesthesia, cost of the procedure, hospitalization.
And discomfort.
And discomforts and scar as well, which might be important for some individual. So more recently, for the last few decades, several other less invasive modalities became available, such as sclerosing agents, or what we call foam or sclerotherapy, and a variety of other procedures that are more recently being used that are even more rewarding as far as success and results are concerned.
So can I ask you just one question? In artery disease, you need your arteries. You can't just remove them. But for veins, it's like you have a whole lot of extra veins, and if you can take out the ability of blood flow to run through the diseased one, then the blood will find its own way back to the heart through less diseased vascular structures. So it's not that you are taking out an inordinate ability to move your blood back from your legs to your heart. You're just having the veins the blood to find a new way to get back to the heart. It's a lot safer.
That is correct.
Yeah.
This is one of the most common questions that I receive from my patients when I'm explaining to them that they are candidates for non-invasive or less invasive treatment of their condition. They ask me, well, doctor, what will happen with that vein that you will get rid of with one technique or the other? And I tell them exactly like what you explained, that we have a pretty extensive and complex venous system, and the essential and the most important system is a deep venous system. Obviously, we cannot get rid of deep venous system that carries more than 80% of the blood flow. So when you remove a certain component of the superficial venous system, the deep venous system will just take over. So that's the important thing. Another thing is when the vein is bad and it's deformed and the valves are destroyed, that vein is useless. Because sometimes the patients will ask me, well, doctor, if I need a bypass surgery or something,
Right.
What will happen? I will not have this vein. Well, the surgeon should not be using the vein that's extremely deformed, aneurysmal, and extremely diseased and so on. So that vein is useless. So I would say from that point of view, there are no consequences removing the vein that's abnormal and that's diseased. Now, what I should also mention, and I didn't mention previously, is there is a medical treatment, of course, of this condition. Medical treatment has been tried for decades, if not centuries, and is not as rewarding, obviously, because otherwise we would not have all those modalities that we have at the present time. And it's very difficult to achieve a very good goal, such as encourage patients to exercise on a daily basis, lose weight to a significant degree, not become pregnant, and a variety of other things that you cannot avoid or you don't want to avoid. You don't want to alter the quality of your life. So it is extremely important to know that whatever, as far as medical treatment is concerned, this is only a temporary solution to this particular problem. Particularly as far as using elastic stockings. Elastic stockings help, and they improve symptoms to a significant degree in great majority of patients, but only while you wear them. So if you don't wear them at night, which might be very uncomfortable, you still get leg cramps at night. So another thing is, a lot of times it will be very uncomfortable to wear elastic stockings, particularly in hot climates.
I was about to say, it's August, this is Houston, Texas, and we have a heat advisory this week. So it's not very appetizing to wear thick stockings. They're not very attractive either. So it's hard with a good conscience to recommend, but in certain settings, they're certainly beneficial.
So I would like to mention very briefly some other modalities that are available, and this is laser treatment, radiofrequency treatment, and then there are certain catheters with sclerosing agents, so-called MOCA, and finally glue.
Right.
Using a cyanoacrylate. This is one of the latest one. And they all have tremendous benefits because they give you high success rate in occluding the vein. I'm talking about 97, 98% success rate, and permanent resolution of problems and symptoms, particularly if you are treating the problem early enough.
So if you wait too long, it's harder to fix.
It's harder to fix. Now, we cannot get rid of hyperpigmentation that occurs in advanced stages. Ulcerations we can cure and heal, but there will be scar there. And of course, you have certain deformities that will stay there forever as residual of infection, of ulcerations, and many other things that happen with more advanced conditions. So, well, thank you very much for the opportunity to be here with us, and I certainly hope that this will be of help to a lot of individuals that were participating in this particular recording, as well as anybody that wants to know more about chronic venous insufficiency.
Perfect. I'm sure it's going to be helpful to a lot of our listeners. Appreciate the opportunity.